Module Overview. Grief and bereavement are inevitable emotional responses to death or the impending death of a loved one. In palliative and end-of-life care, supporting families and caregivers through this journey is as critical as caring for the patient. This module explores the psychological, emotional, cultural, and spiritual dimensions of grief, while providing professionals with the skills to offer holistic, trauma-informed, and culturally appropriate bereavement support. You will learn to recognize normal versus complicated grief, provide anticipatory guidance, support families before and after death, and refer them for further care when necessary. The module aligns with World Health Organization, WHO, Palliative Care Framework, National Institute for Health and Care Excellence, NICE, End-of-Life Guidelines, Hospice and Palliative Nurses Association, HPNA, Competency Standards, African Palliative Care Association Bereavement Toolkit. Learning Objectives. By the end of this module, you will be able to define and distinguish between grief, mourning, and bereavement. Recognize types of grief, including anticipatory, complicated, and disenfranchised grief. Understand the stages, cycles, and trajectories of grief. Provide emotional, spiritual, and practical support to families and caregivers. Identify cultural and religious factors that influence grieving processes. Facilitate bereavement follow-up services and referrals. Communicate compassionately during and after the patient's death. Develop institutional and personal bereavement care plans in line with professional standards. Section 1. Understanding grief and bereavement. Definitions. Grief, the natural emotional response to loss, can be physical, emotional, spiritual. Mourning, the external expression of grief influenced by cultural practices, e.g., wearing black, crying rituals. Bereavement, the period following a loss, typically marked by grief and mourning. Dimensions of grief: emotional, sadness, anger, guilt, loneliness; physical, fatigue, weight changes, sleep disturbances; cognitive, confusion, disbelief, preoccupation with loss; behavioral, crying, social withdrawal, restlessness; spiritual, questioning faith, seeking meaning. Section 2. Types of grief. Anticipatory grief begins before the actual death, e.g., family of terminal patients. Allows early emotional processing but may be misunderstood. Normal grief, expected, time-limited, and culturally appropriate responses, follows typical grief stages or cycles, Kubler-Ross model. Complicated grief, prolonged or intense grief that disrupts functioning, may require professional therapy. Disenfranchised grief, grief not acknowledged socially, e.g., death of a pet, miscarriage, death of a same-sex partner in an unrecognized union. Cumulative grief, results from multiple losses or unresolved grief, common in caregivers who've witnessed many patient deaths. Section 3. Grief, Theories and Models. Kubler-Ross's 5 stages: denial, anger, bargaining, depression, acceptance. Note, these are not linear and may be experienced in various orders. Dual process. Model, alternates between loss-oriented coping, crying, mourning, and restoration-oriented coping, planning, adapting. Worden's tasks of mourning. Accept the reality of the loss. Process the pain of grief. Adjust to a world without the deceased. Find an enduring connection while moving forward. Section 4. Supporting families and caregivers. Before death, provide emotional preparation, what to expect physically and emotionally. Explain care plans transparently. Encourage farewells, memory-making, last wishes. Offer spiritual care and rituals. At the time of death, be present, silent, and emotionally available. Explain physical signs, gasping, cold hands. Give families time with the body. Avoid rushing decisions. After death, provide grief materials, respect cultural mourning practices. Assist with next steps: burial, death certificate, estate matters. Schedule bereavement follow-up, calls, visits, support groups. Section 5. Cultural and religious influences on grief. In Nigeria, mourning may include community gatherings, clothing codes, and extended family involvement. Islamic traditions emphasize burial within 24 hours, while Christian denominations often include vigils and hymns. Some cultures suppress open emotion, others encourage it. Professionals must understand and adapt care without imposing personal beliefs. Section 6. Risk factors for complicated grief. Sudden, violent, or traumatic deaths. Lack of social support. Unresolved conflict with the deceased. History of depression or anxiety. Financial dependence or caregiver burden. Early assessment and referral are key. Section 7. Bereavement interventions. One-on-one counseling. Peer-led support groups, grief education and workbooks, memorial services or tribute rituals. Spiritual care via chaplains, imams, or traditional leaders. Referral to psychologists or grief therapists when needed. Hospices should provide at least 12 months of bereavement support, as per WHO and HPNA standards. Section 8. Documentation and ethical considerations. Document all family interactions, referrals, and grief assessments. Ensure confidentiality and trauma-informed communication. Be cautious of boundary crossing during prolonged support. Avoid assuming all family members are grieving the same way. Section 9. Self-care for professionals. Grief affects healthcare workers too. Encourage debriefing sessions, mental health days, access to employee wellness programs, boundaries and emotional processing strategies. Compassion fatigue and vicarious trauma are real. Accreditation bodies require wellness safeguards. Module summary. Grief is not a problem to fix, but a process to compassionately support. In palliative care, providing structured, culturally respectful, and professionally guided bereavement support is a core service, not an afterthought. Professionals who understand grief not only help families heal, but they also strengthen trust, reduce trauma, and promote healing that lasts far beyond the clinical encounter.